Good morning, good afternoon, good evening, wherever you are in this world of ours. I truly hope that you're all safe and healthy. I'm Aaron David Miller, a senior fellow at the Carnegie Endowment for International Peace, and welcome to Carnegie Connects, a virtual conversation about issues of critical importance to America and to the world. It's perhaps one of the cruelest ironies of our age that the very globalization and interconnectedness that helped spread the virus and the pandemic cannot be easily harnessed in an effort to find a solution on a globalized scale. I guess we shouldn't be surprised. COVID-19 may well be the most impactful event in our world since the Second World War. But instead of bringing the world closer together, it seems only to have reinforced pre-existing trends of great power competition. It's battered a liberal internationalist order that is not so liberal, internationalist, and orderly. And it's created intense polarization and partisanship between and within countries. Nowhere is this challenge more acute, seems to me, than in the challenge of vaccine nationalism. We can all applaud the fact that 500 million doses have been administered globally, and yet billions of people haven't received a single shot. And the haves versus the have-not problem is growing. A recent WHO estimate, and Dr. O'Brien can correct me if I'm wrong, suggested that 2% of the 690 million doses administered globally have gone to the African continent. Estimates by the Economists Intelligence Unit suggest that some 85 countries, a little less than half of those in our world, may not be fully vaccinated until 2023 if we're lucky. So what the world seems to have is a severe case of vaccine inequality. And aside from the moral hazard of not vaccinating all and not launching a serious effort to do so, lack of a global rollout promises a lot of misery ahead. One researcher opined that evolution will punish delay. And the virus has already mutated into several worrisome variants that are going to continue. And what if large populations remain unvaccinated for long periods of time? Aren't more mutations inevitable? The B117 mutation is now reported to be in at least 114 countries. And then you have the economic challenges and dysfunction of not creating a globalized rollout for vaccine. So what's to be done? The urgency seems evident. As one analyst quipped, this is the only arms race truly worth winning. The only arms race truly worth winning. But how do we get our vaccinated arms around the problem? Is funding and working through the nonprofit COVAX the best way to move ahead? How do developing countries set up administrative and delivery mechanisms to get shots into arms? Which of the vaccines are best suited to mass distribution? And how do we overcome resistance to licensing vaccine technology and getting intellectual property rights eased? And then, of course, there's the sovereignty issue. How do you deal with sovereign countries who have their own interests and sensibilities? Fortunately, I don't have to answer any of these questions today, but we have three extraordinary panelists who can. Let me introduce them. Peter J. Hotez, MD, PhD, is a professor of pediatrics and molecular virology and microbiology and the founding dean of the National School of Tropical Medicine at Baylor College of Medicine, where he is also the coordinator of the Texas Children's Center for Vaccine Development. He's the author of Blue Marble Health, an innovative plan to fight diseases of the poor amid wealth and vaccines. Vaccines did not cause Rachel's autism, my journey as a vaccine scientist, pediatrician, and an autism dad. Dr. Kate O'Brien is director of the Immunization, Vaccines, and Biologicals Department at the World Health Organization. In this role, she's responsible for leading the WHO's strategy and implementation to advance the vision of a world where everyone, everywhere, at every age, fully benefits from vaccines for good health and well-being. Dr. O'Brien also serves as WHO's technical lead of the COVID vaccine pillar, COVAX, a part of the Access to COVID Tools Accelerator, Act A. The mission of COVAX is to deliver 2 billion doses of COVID vaccine by the end of 2021 to help end the acute phase of the pandemic. And finally, Dr. Muhammad Ali Pate is the Global Director of the Health, Nutrition, and Population Global Practice of the World Bank and the Director of the Global Financing Facility for Women, Children, and Adolescents based in Washington, D.C. Dr. Pate was until recently the Chief Executive Officer of Big Win Philanthropy based in the UK, and prior to that had held several positions, including that of Minister of State for Health in the Federal Republic of Nigeria. Accomplished presenters, an incredible timely panel, and with that, let me turn the virtual space over to Dr. O'Brien. Thank you so much for coming.
Thanks so much. I'll just take 4 or 5 minutes here to try to address the 2 questions that you've put before us, which is, the first is, can we accomplish vaccinating the world? And what if we don't do that? What are the risks? What are we actually facing here? The first thing that I think we have to acknowledge is we've all heard the phrase that nobody is safe until everybody is safe. No country is safe until every country is safe. And I think we have to put some specificity around that. This is not just a slogan. This is not just a feel-good statement about equity or fairness. This is really about how to end this pandemic. We have seen that this virus is going to do whatever it can and will to evade immunity. It's going to do whatever it can and will to continue to move from person to person to survive. This is a new virus that is changing. It's mutating, and we're really sailing the ship as the ship is being built. What's really clear is that the virus doesn't recognize borders. It doesn't recognize income strata. And so from simply a biological perspective, the urgency and the need to assure that we can get vaccines to all countries around the world, given that this virus has produced disease in all countries around the world, is of paramount importance. And we're not going to get out of this unless we actually have that equitable distribution of vaccines, because we're simply going to be battling one strain of the virus after the next without actually approaching this from an equitable perspective. We also know that we have unbelievable success of these vaccines. Never in the history of the world have we had as rapid development of vaccines that are as highly effective as the ones that are at hand. And so these assumptions that we had that we were going to be in a supply constraint are true. However, we've gone much more quickly in terms of development of vaccines and the availability of supply than anybody really imagined that we would. And that's actually opened up a very interesting and challenging situation. We envisioned a year ago 2 sort of worlds that we might live in. One is where access to vaccines was really only for countries that were the wealthiest countries and could outbid and outcompete other countries. Another world was where all of the vaccine that was being developed would be aggregated into one mechanism to fairly and equitably distribute the vaccine. And that was the vision of the COVAX facility. Recognizing that there would be a small number of countries, that was the assumption, that would be going out and undertaking bilateral arrangements. But we're in a hybrid world now, and we're actually only about 20% of the supply is actually seated in the COVAX facility. And so much more of the supply distribution of vaccines is being determined by a country's wealth and the ability of a country to undertake bilateral deals. So what does this actually mean? Well, I think it means a couple of things. First of all, right now we have over 800 million doses of vaccine that have been actually delivered, meaning put into people, administered to people, 815 million doses. And half of those doses have gone to countries that are of high income. Only 0.2% of those doses have actually gone to people who live in low-income countries. That's not an equitable world, and it's nowhere even close to an equitable world, and it's not driving at the biology of what we need to do to actually get ourselves out of this pandemic. So I think the essential thing here is we can accomplish this, but we really have to take very seriously what actions countries and organizations around the world are actually willing to sign up for. And the first is that we do have supply constraints. There's not enough supply right now to immunize everybody around the world who would need vaccine. So we really have to increase the amount of supply from key manufacturing sites and extend the number of manufacturing sites as quickly as possible. The second is the issue of vaccine nationalism is a real phenomenon. We are seeing countries battling with each other, not just for the number of doses that they have in their deals, but when those doses are going to be delivered. And that's an issue that only countries can address through their dose sharing and through their willingness to allow the highest risk populations to be immunized first in all countries around the world, and take their turn to immunize lower risk communities. The third is the variants of concern. And these are still unclear exactly how they're going to threaten vaccination. This is an area that is going to have to be watched really carefully, and adjustments to the vaccines made when it's necessary, but it may not be necessary for each of the variants of concern. I think the biggest thing that I want to emphasize is that this is not just about health. This is about our economic and social opportunities. And we have certainly seen analyses that quantify from an economic perspective what the cost is of failing to invest in all of the solutions that are needed to increase the supply, to assure that there is access to that supply for all countries around the world. And those costs are in the trillions of dollars. And yet they are a rounding error. To invest in manufacturing equitable supply is simply a rounding error on those economic loss numbers. So this is of urgency, of course, to do this. And the investment case, the business case is really obvious. So I'll finish there. I'll turn back over to you and look forward to the comments from others.
Dr. Brown, thank you. Jerome Powell actually was quoted the other day to the Fed saying that economic activity to resume for the benefit of the health of the global economy really is going to depend on getting a handle on COVID. There was a RAND study indicating that losses of $1.2 trillion a year are expected, and the drain is going to be considerable. Thank you so much. A scary presentation for sure. Dr. Pate, can I turn things over to you?
Thank you, Aaron. I'm glad to follow on the footsteps of Dr. O'Brien in terms of her remarks. I think what we're seeing unfold, the pandemic has become like a mirror on the state of the world. And what we're seeing is not unexpected in a way, given what we know about this new virus and how it is unfolding. Rather, the system that we have, in a way, producing the results that it was meant to produce, in a sense. So COVID-19 is an extreme event. It's an extreme event because of the new virus that has sort of found its way to human populations. With unfolding health crisis, which has affected all countries, high-income countries, upper middle-income countries, and the low-income countries, I think we've seen the devastating impact in terms of lives, but also the disease that it has unleashed on populations. But the secondary crisis that it has unleashed is also significant. I think WHO late last year revealed that more than 90% of countries reported disruption of basic health services, care for non-communicable diseases, as well as things like mental health services because of the disruptions due to the pandemic. So in addition to the direct consequence of the pandemic, we've got a secondary effect of the disruption of the services that the pandemic unleashes. And then, even though the health consequence, in fact, is a starting point, but the biggest brunt of this pandemic in some ways is all the economic fallout. As Dr. O'Brien was mentioning, we've seen a contraction of minus 3.5% of global GDP, according to IMF, with huge variability across countries. More than 150 million people being pushed to extreme poverty by the end of this year as a consequence of the economic fallout of 2020. We saw the contraction in 2020 and now the recovery, which is strong, but there's already a fallout and the disproportionate impact of that across economies in terms of those who are able to actually respond and those who are not. But within countries, it has also disproportionately affected the poor, women, youth, and those who depend on contact jobs and the frontline providers. That inequality is another dimension that the pandemic has sort of brought to the fore in terms of who it has affected disproportionately, those who don't have access to digital services. I'm sitting in Nigeria at the moment. I can tell you it's a tiny fraction of people that are able to have the luxury of doing the work that I do by connecting through the internet and connecting to my daily work in Washington. So, as you mentioned, Aaron, this is an evolutionary fight that the virus is unleashing on human population, human species. The question is, are we smart enough to deal with it in that way? And the surges and the variants, I think, are here to stay because the virus is very smart. And I'm not sure at this moment that we've sort of internalized the consequence of this over the medium, longer term in terms of what it means, given the severity of what is unfolding. So vaccines offer, I think, the best path for getting out of this, for controlling the virus or stopping transmission. I'm not sure we can eradicate it, but at least to control it, to stop transmission, I think vaccines offer us the best path to be able to do that. But vaccines only work when they actually are deployed. And unfortunately, we're seeing, as Kate has eloquently outlined, it's not only the supply of the vaccines, but the ability to deliver them. Even countries that have them, many of them have not yet delivered to the pace that you would expect for the small doses that they have. But the bigger issue is that few countries have really accumulated all the supplies of vaccines, or largely more than 90% of this are concentrated on a handful of countries, and the rest of the world does not have it. That is the state of the world. And the pandemic only reflected that on all of us. That's the world that we live in, where there are huge inequalities. So to answer the question on why, I think it's very clear. To stop the transmission, to control the infection, to really control the evolution in a way, if we can be able to slow it down. The faster we vaccinate, the better. But to alleviate the impact of this pandemic on those who are unable to get their job or work because of what the pandemic might be able to do to them, or cannot afford the care or the medical consequence of it. 70–80% of folks, let's say in Nigeria, reported that they are unable to access basic services because of affordability issues. So the economic consequence of this is quite really significant, particularly on the poorest populations within countries and between countries. And the impact on the poorest countries is significant. So the reasons are very clear. But extreme events need really extreme measures, exceptional measures. I'm not sure over the last 1 year, if there's one thing that we have learned, that we haven't really stepped up to the level that is needed in terms of decisively stopping this pandemic. If it was something else, perhaps it would be different. But I have to say that the challenge has been largely political in terms of the actions that are needed to have a decisive stop on this for the whole global community. Instead, what we've had is piecemeal and country first, as opposed to the global community first in terms of this pandemic. I think it can be reversed. I think the investments need to be done. But alongside that, other public health measures need to be maintained so that the vaccines and also the public health measures and other public policies, including social safety nets, come together to alleviate the fallout from this pandemic. It's not only the virus, but the consequences of it go beyond just the medical issue. So I'll stop here and hand it over to you, Aaron.
Dr. Pate, thank you so much. You know, honest analysis often leads to paralysis, and you've given us some clear ground truth on what the challenges are. I'm just hoping that we can find a way in the to-do category to meet that challenge. Dr. Hotez, let me turn matters over to you.
Yes, well, thank you very much, Aaron, and thank you for organizing this. This is a fantastic hour and an event, and I appreciate the opportunity of participating. And I love the comments of my two colleagues, and it's a real honor to be with both of them. A couple of things that I want to say, and then we can, you know, go more to a discussion, and that is, uh, we learned new things with each pandemic. And, people often say, well, why do we never learn lessons? Why do we always get caught flat-footed? It's not entirely true. We have learned lessons with every pandemic. In 2003, after SARS, we put in place IHR 2005, International Health Regulations. After the H1N1 pandemic for pandemic flu, we put in the Global Health Security Agenda. After Ebola in 2014, a number of leaders met at Davos to create CEPI, the Coalition for Epidemic Preparedness Innovation. So there are improvements with each pandemic, and there are some things that have gone right with this one. And I think one of them is the COVAX sharing facility. I have to say, when the story of this pandemic is written, and there are not a lot of silver linings on this, but one of them is how global leaders got together and created COVAX and created the ACT Accelerator. And I'm on a Lancet commission for COVID-19 vaccines, and some of my colleagues on there actually credit Dr. O'Brien with being one of the brains behind the COVAX sharing facility, and so thank you for that. I think it was well designed. I think it's extremely thoughtful, but it's not going to solve all of our problems. And I think there were two issues that I see both upstream and downstream from COVAX that need to be fixed both for this pandemic and for future pandemics. One of the upstream things that need to be fixed were some deficiencies in the science policy failure. And science policy is not a well-shaped area. When you look at public policy in general, science policy is often the poor stepchild of all public policy. And that kind of showed through, because I think the mistake that was made upstream from COVAX was that when people got together to say, what vaccines do we need, I think there was an excessive amount of attention on innovation. Innovation seemed to be the priority. And the consequence of that is we made some good vaccines, but they don't have necessarily the capacity to filter to the low and middle income countries. So for instance, I got the Pfizer-BioNTech vaccine. It's a fantastic vaccine. The Moderna is a fantastic vaccine, but they tend to be, one is a Lamborghini and the other one is a McLaren. They don't have the ability to scale for the world. There's limited capacity. It's not that people have bad intention. Pfizer-BioNTech has donated 238,000 doses of their vaccine to Rwanda, but it's a drop in the bucket. Look at the scale of what we need to do. We have 1.1 billion people in sub-Saharan Africa, 650 million people in Latin America, about 400 million people living in the smaller low-income countries of Asia. That's 2 billion people. That's 4 to 5 billion doses of vaccines. It's not going to happen with the mRNA vaccines. Now, downstream, yes, the technology will improve, it will mature, it'll be easier to scale, and maybe in 5 years' time it'll be easier to scale, maybe keep stabilized at room temperature, but not now. And then the other focus was the adenovirus vector vaccines, which are also good vaccines. And yes, they have better ability to scale, but anytime you rely exclusively on a brand new technology that's never been scaled and give to large populations, you never know what's going to be the performance in terms of safety and efficacy. And now we're dealing with this problem of cerebral thromboses, which I hope we can get around, and I'll come to that in a minute. But my concern is that there was not enough attention to making old school, durable, low cost, unfussy vaccines for countries in Africa, Latin America, and some of the poorer countries in Asia. And that has to be fixed because we need 4 to 5 billion doses, and we need it relatively soon. One of the things that we're doing is we've developed a low-cost recombinant protein vaccine in collaboration with Biological E. They're one of the big vaccine manufacturers in India. We think we could do it for $1.50 a dose. It's looking great in non-human primates, looking really good in phase 1-2 clinical trials. And I hope that can make a difference. They're scaling it up now to 1.2 billion doses. But the hard part was in the first 6 months of this pandemic, I was raising money to support it because nobody had interest in an old school, boring recombinant protein vaccine made by microbial fermentation and yeast, the same technology used to make the hepatitis B vaccine. So there was a failing there that everybody ran to what I say in my frustration sometimes, the shiny new toys. And we made some great shiny new toys, but they don't have the ability, I think, to scale for poor countries. So that's problem. That's the upstream problem. The downstream problem, so that COVAX doesn't have an adequate supply of vaccine that it needs to do its job. So COVAX was well constructed, but the upstream part didn't work as well as it should have. The downstream part is we never really dealt with all of the, and I'm sure we'll talk about this, all of the anti-vaccine aggression and the anti-science empire. And it has two major components to it that both the United States government and the United Nations agencies historically have not been willing to confront. We now know that the Russian government under Putin has launched a very sophisticated program of what's called weaponized health communication in order to destabilize democracies, filling our social media and internet with anti-vaccine messages. We know from reports from the U.S. State Department and from British intelligence and the Foreign Affairs Office in the UK that the Russian government is specifically targeting Western vaccines to discredit them. There's not been engagement with the Russians to do that. We also know the largest share of anti-vaccine activities is coming out of the U.S. I'm here in Texas. I'm sorry to say it first rose out of Texas, and now has nationalized, and now it's become a main. Before it was a fringe movement to the extreme far right of the Republican Party. It is now a mainstream element of the Republican Party. Defiance of vaccines is considered a badge of honor, and you're seeing this play out nightly now on Fox News with Tucker Carlson now going on nightly rants about vaccine, and Laura Ingraham attacking me and Tony Fauci and other scientists. So this is a problem. We've not been willing to confront the anti-vaccine aggression. The message has been for the last 2 decades that, Peter, we're not going to call this out and call attention to it because it'll give it oxygen. And oblivious to the fact that people no longer use compact computers with dial-up and Ask Jeeves. You know, the internet has expanded and has reached far beyond that. And we need a more confrontational approach, because now this is going to be a big problem with the AstraZeneca and J&J vaccines, because we're seeing across Africa and Latin America severe doubts about using those adenovirus vectored vaccines. And, you know, we don't have a lot of other options. You know, hopefully our vaccine will get up, but we have limited options. And if there's widespread refusal of those 2 adenovirus vaccines based on a real concern and an appropriate pause, but an unwillingness or an inability to deal with this anti-vaccine empire that's amplified it, this is going to be a problem as well. So good news, bad news story that I see coming out of this.
You know, that's usually the case. Life's usually not about transformations, but hopefully effective transactions that can deal with problems. You have a new book coming out, Preventing the Next Pandemic, Diplomacy in a Time of Anti-Science. And I wanted to ask the 3 of you, we had John Barry, the author of The Great Influenza, on this program during the height of the early days, April or May of last year. Barry basically said, I asked him, what's the most important lesson that emerged from the Great Influenza? And he was very, very clear and very simple. Tell the truth. Tell the truth. And in a world of sovereign nations, many of whom have all kinds of ambitions and desires to either run away from the problem or to exploit it, this is a huge, huge issue. So I just wonder, let me ask Kate and Dr. O'Brien and Dr. Pate, whether they have, in their experience, how does this issue of leveling with people figure into an effective campaign to start with you?
Sure. I want to reflect the tell the truth is such a, it's so simple and it's so obvious. I'm a pediatrician and infectious disease specialist. And one of the things that, just as you were saying that, one of the things that really resonated for me is I learned very early on that the mother, it was often the mother who was bringing a child in, knows exactly what is wrong with the child until I prove otherwise. And the reason that came to mind when you said just tell the truth is that people are so aware of their health status. They do understand what's going on. They're the most able to understand risks and understand what they most want in their lives for health. That we really don't have anything unless we can rely on our own health and to protect. It's the fundamental desire of every parent for every child. And we do talk about vaccines as protecting the adult in every child. And in this case, when we're talking about COVID vaccines, it's about perhaps protecting our older years in every adult at this point. So I think that what in my experience, what we've seen is it doesn't actually matter what community you're working in. When you actually are transparent, honest, and clear about what we know and what we don't know, I think people in general, and I'm not saying it's everybody, I think people in general have confidence and can see the honesty and the transparency and the authenticity of that. And I think that we are, first of all, not just honor bound as a medical community, but it's the only effective approach is to speak the truth about what the situation is, what we know, what we don't know, and when we're going to actually provide more information. And in all of our communication and our efforts through WHO is about credible information. And I think this is what has gone so wrong in a very contemporary era, is there is so much access to incorrect information, misinformation. Some of it is very deliberate, as Peter has referenced. And it's really difficult for people to distinguish those parts of information that are credible and accurate and those that are not. And I think that's where the importance of sort of science literacy and information literacy comes in, is being able to make those distinctions between what are pieces of information that you can rely on and which are the pieces of information that are intentionally trying to frighten, deter, scare people from what they would otherwise choose for their own benefit and the benefit of their families. That's how I've experienced it in communities all over the world.
Makes a lot of sense. Dr. Pate, do you, based on your experience, what about telling?
Yes, I would say at the end of the day, it's trust.
Yeah.
Whether someone really gets information and uses it or not, it's whether or not they can trust you. And that trust is not given, it's earned. And how do you earn it? Telling the truth is one way to earn the trust. But we have a situation where institutions in many places, I think, have their own fundamental legitimacy eroded either by virtue of what they've been unable to do or what they have been able to do in a different direction from people's expectations. So with that, you have lack of trust inbuilt, and institutions have to regain them, whether government, whether international organization. I'll give you an example. Polio eradication was almost derailed by what happened in northern Nigeria many years ago. WHO, UNICEF, federal government of Nigeria all worked very hard to regain the trust of communities. But that was not until the program was able to engage with other institutions that are perceived to be more legitimate than the frontline state institutions. That is a traditional religious institution in those particular areas. And with a full disclosure on what is going well, what isn't in the program, including on things like circulating vaccine-derived polioviruses, which was an issue because the perception was that the vaccine itself was also contributing to paralyzing children, which may in fact be the case, but that the information had to be shared transparently, not sort of swept under the rug. And I think a determined effort to regain the trust of the communities opened the space for the technical interventions, the managerial actions to actually work. So in the context of this pandemic, for instance, I think all institutions ought to soul search in terms of the degree to which they are sort of being honest, being fair and square, as opposed to spinning or positioning for one or the other reason. And that's not limited to governments in developing countries, but governments in developed nations. And it's also not limited to non-governmental institutions or the private sector or multilateral institutions. All of us have to really come clean in terms of being transparent, being truthful, and to earn the trust of those whom we're trying to influence. That's all I will contribute at this point. Yeah.
It makes a great deal of sense. You know, Dr. O'Brien, you used the term "we" when you talked about what an RX.
Aaron, can I just make one comment about that?
Peter, sure, go ahead.
Yeah, and I think it's a really important point. And along those lines around trust, I mean, if you look at three of the worst affected nations with COVID-19, the United States, Brazil, and Russia, which is grossly undercounting the cases and deaths, what do you have in common? You have governments, at least last year, and now with Brazil into this year, that downplayed the severity of the pandemic, attributed COVID deaths to other causes, discredited masks, said the hospital admissions were due to catch up elective surgeries, and the list goes on. They spectacularized hydroxychloroquine and other non-functional interventions. And that was a major reason why people died. The reason 500,000 Americans died from COVID is partly because of the SARS coronavirus type 2. The other is showing political allegiance by defiance of masks and social distancing. And so I think that's really an important lesson. There's even, some even use the term medical populism around that. But this is clearly talking about trust and to echo David Berry's words, I think that's absolutely the case.
Kate, I want Dr. O'Brien. I keep looking at Kate O'Brien. Dr. O'Brien, let me ask you. You use the term "we," and I do it all the time in reference to solving problems, and I'm not entirely sure who the "we" refers to. You have I won't even call it a community. You have a reality of 193 or so sovereign nations that sit in the UN. You have international organizations like the WHO and others. But when we talk about defining a strategy and marshaling the means to an end that is unprecedented in the history of our species, vaccinating, 7 billion humans in a relatively timely fashion. Somebody or buddies has to get their arms around the problem. Now, I would ordinarily look to the United States, but I think for many reasons over the last several years, that's been fraught. It's much better now. But even our role, even the U.S. role as a leader in this effort, I think has lagged. So when you define a strategy toward a global problem in a world of sovereign nations, who does what?
This is not a short question to answer, but I'll try to put some shaping around an answer to this. The reason I use we is that it is an unspecified we. And the reason it's an unspecified we is that it takes the contribution of all institutions and all individuals. That's not to say that every single institution in the world has a specific action that needs to be taken, but every individual has at least some role to play in the influence of their government, in the influence of where they decide individually to put their own personal assets, in their decision about what's fair and what's not fair, and how they'll participate in a fair or an unfair world. So there is a role for everybody to take their position about what kind of world they want to live in. And I really do believe that everybody has some element of power to exert that role. When we look at what's happened, I don't want this conversation to be a really negative conversation, because I think there has been so much that has been achieved in a very short period of time. And I'll just focus a little bit on COVAX. It is the largest multilateral undertaking since the Paris Climate Accord. And just if we get our hands around that, the number of years that it took to get to an agreement on the Paris Climate Accord, the COVAX facility was not just conceptualized, designed, executed, and is in business in less than 12 months. It is the largest multilateral undertaking since the Paris Climate Accord that did all of that in less than a year. It's extraordinary. We invested in an R&D pipeline to secure global access, have built the most diverse portfolio across manufacturers and technical platforms, not knowing which technology was going to work, granted emergency use listing for global use and harmonizing a regulatory system, created an indemnification and liability approach to create the first no-fault compensation mechanism globally for vaccines, established a new fair and equitable allocation mechanism that is real and that is working. So there is so much that has happened in an incredibly short amount of time, and it didn't happen by accident. It happened because people in institutions said, this is the kind of world that we want to be part of, and this is the kind of impact we want to have, because there's no other way out of this. There isn't actually another choice around this. And I think that's the thing that we have to sort of really emphasize. The we, it's all of us. It's all of us as citizens, voters, participants in leadership positions, non-leadership positions, in whatever way we live out our lives. So I think that's who the we is.
Thank you for that, Dr. O'Brien. I mean, one of my favorite sorts of tropes is, particularly over the last 4 years, having worked for both Republicans and Democrats and voted for Republicans and Democrats, is the difficulty we had in turning the M in me upside down. So it literally becomes a W in we. And in fact, if we needed a challenge to which that should be applied, we now have one. But does COVAX, I mean, countries are negotiating their own supplies with pharmaceutical companies, in addition, correct, to benefiting from COVAX. I mean, does that mess up the system, or is that the wave of the future?
Well, I think, as I said before, I think the ideal world, and we don't live in an ideal world, but the ideal world, and this is where all actors come in, and we haven't spoken about the manufacturers, and the manufacturers have done extraordinary things. Let's make no mistake about it. The manufacturers are an absolutely critical part. There is no product without the manufacturers. But we also have to hold accountable the behavior of the manufacturers. I think these are the lessons that actually we will take out of this pandemic is, questions that we have around early decisions that were made by governments, by manufacturers about how they would participate, how they would shape their role in the global response. And we've ended up in a place that I don't think we imagined. We ended up in a place where there are a lot of actors who are behaving in a competitive fashion with their elbows out, and one collaborative set of actors who are working under a different paradigm. And I think this is one of the big lessons, is what are the elements that led to the COVAX facility not being able to be the same competitive actor in those early days when deals were being struck. And we didn't know which products were going to be successful and available. And I think there's a fundamental difference between the COVAX facility and the bilateral deals that have been done. And that is that in the very early days, high-income countries had a treasury that sat behind them, right? They had access to an unlimited amount of money because they sit in front of a treasury. And an entity like the COVAX facility could only do deals to the extent that it actually had hard money available to it. And that took time for donor countries to put in place.
Yeah.
And so where there was a timeline that was highly competitive, not entirely about getting a volume of supply, but about the access to early doses. And we're in a very early phase here. We're 3 months into the deployment of vaccine. And this is the inequity that we're seeing, is access to early doses, which is a different aspect of this than access to total numbers of doses eventually.
Right.
And I think that's one of the big lessons here, is that if we want a structure, a treaty, a new structure going forward, because we will have another pandemic. We don't know when it's going to be. We don't know exactly what pathogen it's going to be. We don't know what the character is going to be. But scientists have been saying and ringing the alarm for decades now that we will have a pandemic, and here we are. And the world wasn't ready. The world did not have the institutions ready. It didn't even have the domestic structures to respond to this. And that's why we are where we are right now. So, shame on all of us if we don't learn from this and say, what we really need is we need a capacitated at-risk facility with funding behind it that can move immediately when we face something like this again. We all have, we live in countries, some of us, at different times in our lives, that put enormous investment into at-risk defense systems that are never deployed. And we don't question that. We say we have them in place because if we needed them, we want them available immediately. I think that's the question we have to ask ourselves about health, is are we willing to put the investment into at-risk investments that may not pay off even in our lifetime, but they are there available the moment they're needed. I don't think we've done that.
Dr. O'Brien, thank you. If 2/3 of the newly discovered pathogens in the world are viruses, then I guess you could expect that we better be prepared for the next one. And clearly we need a new definition of homeland security here, because when the real threat to the Republic came, it did not come from transnational jihadi terror. It came from a virus. Let me ask Drs. Hotez and Pate just one question. I know Dr. Hotez wanted to offer a comment. Fine. How big a problem are licensing agreements and intellectual property rights in this whole issue of equitable distribution of vaccines? And what can be done?
So just to finish up, and it's related actually with the last point. I think, what Kate said is absolutely right. I think one of the problems is we don't have a sustainable finance model for developing new vaccines. I mean, CEPI is a great start and really important, but we need to amplify it, and we need to do some things differently. I mean, if you look at the major companies that are producing COVID-19 vaccines, it's interesting that the biggest players, Merck, GSK, Sanofi, are not necessarily in this in a big way, at least not so far, right? The companies that are in this are not traditional vaccine companies, BioNTech, Moderna, AstraZeneca. And the attraction, I think, for a lot of those companies was this was a way to accelerate their new technologies. And they also got, in some cases, got a lot of support to do that, and also provided a mechanism to get through the regulatory hurdles. And there's not I don't think it's so much the financial incentive for COVID-19 vaccines, but now they'll be able to apply that mRNA technology to cancer vaccines, to vaccines for neurological degenerative disease, and things along those lines. And that's really important. But I think it's extremely instructive, and a reminder that we need parallel models. The multinational pharmaceutical companies do a lot of important work. They provide a lot of vaccine for the Gavi Alliance and for immunizing the world's children, but we need other things in place. And among them is we have to expand vaccine development and production capacity locally. Right now, for all practical purposes, no vaccines are made on the continent of Africa. No vaccines are made in the Middle East, barely anything of substance, even in Latin America, a little bit in Brazil and Cuba, but not nearly enough. And I think that's one lever we can pull and push, is to build up that capacity. And it's not just building bricks and mortar, because that's the least of it. Building the factories, it's the human capital, training them how to do vaccine science, how to do regulatory science, how to do quality control and quality assurance. I mean, and that was one of the problems with the Russian vaccine. We have no idea about pharmacovigilance, what's happening there. We don't know about the quality control, quality assurance, and it's not so much that it was such a heroic scientific feat, calling it Sputnik 5, but it's all of the belts and suspenders that you need around vaccine development. So we need to build that in. So getting to the intellectual property question, I tend to be an outlier on this one, just for full disclosure. Having worked in developing vaccines for so many years, for me, the intellectual property was never the biggest hurdle. It was always about the trade secrets, the technical know-how, the training, how to do quality control, quality assurance. Yes, there are some intellectual property barriers, but it's not the same. I think a lot of people use the CIPLA model for HIV/AIDS drugs, and for vaccines they're so different, because a lot of it is the complexity in making and scaling it up. So even just to be provocative, if you were to liberalize all of the patents tomorrow, it would not have an immediate impact, because I don't think that's the biggest barrier. It's not a zero barrier, but if I were to make my priority list, that would be way down in terms of intellectual property.
Thanks. Dr. Pate, did you want to offer a comment on this?
Yes, I think very little to add to the excellent remarks by Dr. O'Brien and Dr. Hotez on this. But I will say that if you're a poor country in Africa today, and you look at the world and you hear the narrative, all the good that has happened over the last 1 year in terms of development, in terms of all the excellent work that COVAX and ACTA have done. But at the moment, you're not getting the vaccines that you need, and you're seeing all the what is happening in other countries. You'll be wondering, when are you going to get yours, at what rate, and what does it mean? What does the global system mean for you? In some sense, 2020 was a defining year where the issue was not the ideas or the institutions or the network that came together in the alliance around Act A or COVAX. But there was fundamentally a failure of political leadership in the world at the point when the world needed it, because several of those actions would have been taken in a different direction had we had key actors coming together. I'm just going to say here, if you had the US, India, China, Europe, African countries all together and say, look, we've got an existential extreme event facing the world. Let's mobilize. The at-risk financing that Dr. Brian was mentioning would have been solved given what has been spent in the stimulus. The manufacturing, the indemnification and liability, the capacities, even the choices in terms of the vaccines to invest in. Dr. Hotez has mentioned the sort of imbalance in terms of the innovative newer platform vaccines versus sort of more traditional vaccines. Now, if we had approached it in that way, I think we would have had a different outcome from what we're experiencing today. But that was fundamentally a facet or a lack in terms of the political leadership at that point, not necessarily the willing institutions, the WHO, UNICEF, Gavi, the World Bank. We've all been talking every week since the beginning of the pandemic. It's more than a year now. But I think there's something else that did not come together as it needed to do. And that I hope we learn it, because what we're seeing today is something that is the fallout of those missed opportunities of 2020. But it hasn't ended, and that there's still an opportunity. And hopefully this week we'll see re-engagement in sort of that sense that will bring the world together for a common enemy to be defeated. So I'll just leave it there.
No, that's a very eloquent description, I think, of one of the main challenges. I think we have come to the end of the hour, and I don't know about our listeners, but based on the authority, expertise, and commitment of the three of you, I'm hopeful and gratified that you were working on this issue. It's an extraordinary challenge, perhaps the greatest global challenge since the Second World War. And hopefully we'll find a way to carry through. I want to thank you, Dr. O'Brien, Dr. Hotez, Dr. Pate, for your presentations, and our listeners for tuning in. I would only conclude by conveying to all of you, think positive, but test negative. Thanks for joining, and take care.
Thank you.